really a very big opportunity for me, and I'm very much honored. And I'm very sorry for the network interruptions. I don't know why they keep on happening whenever I'm given an opportunity to present. My name is Tito Ismail Musoke. I am a pharmacist working at Untitled Chapter Hospital and a registered member of the Pharmaceutical Society of Uganda. Today's presentation is about sharing experiences and the roles of pharmacists on the COVID-19 response team. Can we go to slide number 2?
Yes, sir. We're on slide number 2.
About the objectives, today's objectives, we expect to share experiences on how we are prepared as the hospital in receiving COVID-19 patients. Objective number 2 will be about sharing the responsibilities of pharmacists on the team, that is the COVID-19 team, which are also explain some of the commodities that we use. It is very important what the Untitled Hospital is. Untitled Hospital has 3 campuses. It has what was formerly known as Grade A, campus number 1, and then it has what was formerly known as Grade B as campus number 2, which is the main campus. It has also another campus which houses the National Isolation Center. So in 1904, I set up a facility to manage their friends, their families, and themselves. I set up a facility to providing health care, and that is what was formerly known as Grade A. In 19 Kawaka Mutesa, who was the leader of the Buganda Kingdom then, set up a sister hospital for management of his common people, and that was Grade B. So, I think around that time also, people sleeping sickness. So the leader set up another facility, which is the isolation center specifically for the management of sleeping sickness. So in 1996, the 3 facilities, that is Grade A, which was for the management of the imperial colonialists, and then Grade B was for the management of common people of Uganda Kingdom and Isolation Center, were all combined into one facility by the government and the Untitled Hospital. And in 2016, Grade B, which is the main campus of the hospital, was renovated, and after the renovation, the hospital was upgraded to a general referral hospital. And last year in July, the hospital was upgraded to and it attained a referral status. So basically, that is about the original referral hospital. And the facility, we have a big capacity of about 250 beds. Slide number 4, Kenneth.
Yes, please. We're on slide number 4.
Yeah. Those are pictures, illustrations of the 3 campuses of the Untitled Hospital. The first is the new refurbished main campus, which was formerly known as Grade. And then the upper one is the Grade A, which has the fence with the state house, and then down the National Isolation Center. Slide number 5.
Yes, on slide number 5.
Yeah, so our journey to COVID-19. Last year around September, there was a global outbreak of the virus, the novel virus, that is coronavirus. That
Ismail? Ismail, are you able to hear us? The phone call is breaking. Hello? Guys, sorry, the phone call dropped a bit. Let me try to call him back. Ismail, you may proceed on the journey of COVID-19 management. Yes.
Kenneth.
Yes, please proceed.
Hello, Kenneth.
Yes, sir.
Am I audible? Can you hear me clearly?
Yes, please proceed.
Hello?
Yes, I can hear you.
So we stop to the slide number 5, right?
Yes. You can go ahead.
Yes, I was briefly talking about our journey in COVID-19 management in the regional referral hospital. So I was saying that around last year in September, the World Health Organization declared COVID-19 a global pandemic, and so the Ministry of Health of the Republic of Uganda earmarked to hospitals, and that is internal referral hospital and the regional hospital to be prepared for any outbreak in the country. That is the Regional Referral Hospital. We came up with an emergency response team. Unfortunately, this team did not include any pharmacists. I thought unfortunate that at that time they thought pharmacists would not be to the team. That's why that we had 6 pharmacists in the hospital. That is I leading the team of plus 5 different pharmacists, but none of us was included on that team. They thought that maybe we were relevant in the emergency response at that time. They just included doctors, nurses, hygienists, and administration and others. So on the 21st of March 2020, the country, that is Uganda, registered her first case of COVID-19. Unfortunately, This was at Entebbe Regional Referral Hospital. This was a 36-year-old male who was coming back from Dubai, where he had traveled 2 days earlier. Slide number 7, slide number 6. Connect.
Yes, please.
So that is a presentation of what is happening at our facility. Unfortunately, Kenneth, you don't have the updated slide of that. That slide has now changed.
Okay.
So where we have the total admission, which is now 166 confirmed clients that the facility has so far admitted ever since it started managing COVID-19 clients. We have admitted 166 confirmed clients. Out of those, 53 have so far been successfully discharged. We after testing negative on 2 consecutive times. And currently we have 111, that is 111 active cases that are admitted in the facility with still having coronavirus. However, out of the 166 clients, 2 of them were referred to Mulago National Referral Hospital for better management. Slide number 7.
Yes, we are there.
So briefly, what was our role, or what is our role on the team, and how we came to be included on that team? Because remember, at first we were not included in the team, but later they saw that team couldn't move smoothly without pharmacists. So what spiked so far the inclusion of the pharmacists on the team? As the pharmacy department, we before the emergence of COVID-19, we prepared SOPs about the preparation of different prosecutions of disinfectant from concentrated solution, and that is specifically because the National Medical Store supplies 6% concentration. So we prepare SOPs on how to dilute this to the required concentration of disinfection, that is which is 0.5 for hard surfaces or 0.05 for soft surfaces. At that time, when there was an outbreak, what was in stock was the liquid jig. And so they could easily interpret the SOPs that we had prepared to come up with the required specifications. So they thought that pharmacists were not relevant since they could read and interpret the SOPs and come up with what they wanted. However, along the way, UNICEF and World Health Organization and Ministry of Health supplied pellets, that is pellets of calcium hypochlorite, 65%. And so the team got stuck. So this wasn't liquid disinfectant, they were pellets. So they got stuck on how to come up with the required concentrations of 0.05 and 0.5% that was required for the disinfection. And so when they got stuck, they had to call in the team. I also made a few consultations, and then I also made a few consultations, and we were able to come up with a required concentration using the previous knowledge of the alleviation and pharmaceutical calculations. So we're able to come up with the required concentrations of 0.5% and 0.05% from the available calcium hypochlorite pellets. That is now started seeing the market in the team. Because remember, this is a novel infection, and so the treatment is not very clear. The treatment and management is not very clear. So our strongest pillar, our strongest pillar, or the strongest pillar was having strong adherence to infection prevention and control measures, that is ICT measures. And so one of the activities involved in there is making sure that we are having the right concentration of the disinfectants and we are using the stairs in the disinfection. So the now that the team value of the pharmacists on the team, and so they included the pharmacy, they called for the of the pharmacists on the team. So briefly, that's a slide number 8, the slide showing the concentrations that we're using something up with a concentration of 0.5% and 0.05%. So that is from the liquid G, slide number 8, and slide number 9 shows the concentrations we use to come up with a concentration from the calcium pellets. Slide number 10 is briefly talking about specifically what's our role as pharmacists, because after including pharmacists, they also called all the 5 intern pharmacists to be of the team, because now the work became overwhelming. Because currently we have 4 coronavirus treatment units, and so they needed pharmacists on each unit to make sure the right full concentrations are prepared, but we also carry out full quality control from those preparations that are prepared. That is the pH of the solutions that we have prepared. For the alcohol, we advocated for the purchasing of the alcoholometer. So before reducing any batch to the treatment unit, you have to make sure that it is above the minimum alcohol content. So we measure the pH of the solution that is being dispatched from the store to the treatment unit. So they had to include all the other 5 intern pharmacists, and so we became 6 pharmacists on the team. And this is what we are doing on the team. Supply chain management role, and this included definitely the activities that are involved in supply chain, that is the ordering, notification, making sure that the items are properly stored, and also ensuring appropriate usage of these items. And the Ministry of Health has an online supply chain system, and that is the electronic emergency logistics management information system, which captures data on consumption and then also ordering of the items with that system. So this is the pharmacists are managing that system. Definitely the ITC role, ensuring that the right systems are used, the right PPEs are used in the different because the activity is divided in 2 different levels. There is level 1, level 2, level 3. Level 1 is where there is no contact with patients and there's no risk of the risk of transmission from a client to another person is very low, such as the triage or the assessment area. Then level 2, this is where the risk of transition from one person to the other is high, such as the treatment, and then level 3 where patients with symptoms are quarantined. So we have to make sure that the right personal protective equipment are used in different zones. For example, we didn't expect someone to go in the treatment room having quarantine patient with a surgical mask. So that's the role of pharmacy to make sure right PPE are used in a different naked story. Then of course ascertaining but the percentage of the alcohol content in the disinfection that is being used, but also the pH of that disinfectants. We are also involved in the preparation of SOPs, regular activities. As a treatment, as a COVID-19 treatment, definitely we have procedures and how we're like. Okay, so we are involved in coming up with those SOPs. Then we are also involved in the preparation of checklists for the different activities that are there. Of course, definitely we participate in the clinical management of patients that are doing good rounds with the other team, that is the doctors on that team, and then the nurses on that team. So that the main two disinfectants that we use in the hospital is the sodium hypochlorite, so calcium hypochlorite solution, and then the alcohol. And those are the different tests that we do on those solutions before we take them to the treatment unit. On alcohol, we have to make sure that the solution that is going to unit is about 70% alcohol content by using the alcoholometer. But also we have to make sure it's within the required range. Then on the calcium hypochlorite, so sodium hypochlorite solution, we make chlorine content, and still we have test strips that when you dip them in the solution, they turn to a color that is and then we compare that color to the standard chart. So when the color of the strip is comparable to the standard chart, then we can confirm that yes, the chlorine content is in the required range. But also the pH of the solution, have to make sure that the pH of the solution is within the required range, and we still use the pH to come up with those tests. Slide number 13, now the picture number 1, that was a team that was going to do ECG on COVID-19 case. Because at the start we started by giving our patients hydrochloroquine. When we didn't have hydrochloroquine, we give them chloroquine. And let these drugs have an effect on the heart. So we used to go in with a cardiologist from Molabo, and we used to ECG on these patients before they started on the drug, and after they had finished their treatment, because the treatment would go for 5 days. So we're still going after the 5 days and take their ECG on the discharge. I just compare and compare the results to see whether there's any effect of these drugs on the performance of the heart. Picture number 2 is I was with one of the intern pharmacists, and we are going to discuss drugs on the patients, and also see whether they had any side effects with the drugs that were given, but also to assess adherence of these drugs to our patients. However, currently, we are no longer giving them hydrochloroquine and chloroquine. So now it's basically management according to the presenting symptoms. For example, the patient has fever, then we do something like that. Slide number 14, Kenneth?
Yes, please. We are there.
Yeah, thank you. Slide number 14, so that is showing what we're doing in the. Slide number 15, those are the different personal protective equipment that the key personal protective equipment that we use, or we are still using in the management of COVID-19, confirmed and suspected cases. One, we use coveralls. These are the white gowns. Okay, you can go back to slide number 14. Yes, those white coveralls with hoods. Those are the coveralls. Then we use the such gowns. You can go back to slide number 14. Okay?
Yes.
The blue ones. Those are the blue ones. Those are the ones we use. We mainly use them for the suspect. Then we use the N95. Of course, we put on the boat. And then with double club, at first we put on That's the examination glove. And then you put on the coverall, then on top you put on the surgical glove. Then we put on the goggles and the face shield. The face shield is what covers everything, the nose, the mouth, and the ears. And on top we put on the disposable apron. The surgical mask, just like I said, we put them on when we are exposed that are not very contagious, such as the affected zone. Slide number 16. There are medicines that we started with. We used to give our patients chloroquine, chloroquine, 200 milligrams twice a day. Sorry, we will start with 400 milligrams twice a day. Then the next 4 days, we taper down to 200 milligrams twice a day because the treatment will go forward. Then we also give our patients vitamin D, and then we give them that is azithromycin or azithromycin. We give them azithromycin if it's available, but if it's available, we give them azithromycin. And then any symptoms of pneumonia-like symptoms, then I will finish them on ceftriaxone. And then of course, most of them paracetamol medicine. We are not giving anything to our patients. Maybe at the symptoms, that's when we start the symptoms. These are the main conditions that use the biohazard bags, the liners, and the boxes. Slide number 18, Kenneth?
Yes, we are there.
Yes, and slide number 18, some of the challenges we are facing, basically as the pharmacy team, on the COVID-19 response team. One, we face a challenge of inadequate numbers on the team. We started by on the team that is one pharmacist and 5 intern pharmacists. But on the outbreak of COVID in the country, the hospital was to spearhead the management of COVID-19, and so the hospital was closed down, completely closed down, from offering the other essential services to specifically offering COVID-19 management services. And so they created different units. And also the health workers, because there were a lot of transport challenges and there's no accommodation at the facility, and so there were very few health workers. So a pharmacist would work at the stores person, ordering of supplies, then reporting, making sure they are protected, preparation of distance, and remember there are 4 treatment units in the facility. So what became a little bit too much, whereby each unit needs like 3 pharmacists sit there and get a single pharmacist is supposed to be about treatment. Enough money, 24/7. The other cutters, our fellow cutters, and the doctors who have shifts. How much we have 24 hours? And then we also had challenges and remember, because the pharmacist is the logistical focal person on the team. So even when you order and you're not receiving from enemies, they think maybe you're not doing your role, and so they start pointing fingers. I think we are doing well. We don't face a lot of sort out those quantities of these people. And at that, it is a very, very big problem. Definitely, we face the challenge of lack of recognition or less recognition, because whenever they talk about the thing that is covering COVID-19 management services, they are mainly pointing out the nurses and the doctors, and they tend to forget the other people at the back that are actually making these people do their work well. For example, the pharmacists, the hygienists, the waste management handlers. Let's take an example. If we are preparing the right concentrations of the disinfectants, that is the G, or if we're not ascertaining the right concentrations of the alcohol in the disinfectants that are being used, definitely people use the disinfections and the virus will not die. And so some people end up contracting the virus. But because we are on top of our game, and we always make sure that the disinfectants contain the right concentration, and so people use them, they are able to achieve that purpose. Probably that's the reason why none of the health workers are getting rid of themselves people as contacted the virus, despite the fact that we are having the highest numbers in the country. However, other facilities that, unfortunately, are having fewer numbers, they have some of their health workers already contacting the virus. But then in the hospital that are handling the biggest numbers in the country, has not had any health worker contact the virus. So probably one of the aspects behind that is because we are always on top of our game as the right concentration of disinfectants that are used in the unit is concerned. Of course, inadequate training. Just like I said, when they were choosing the team to prepare for any outbreak in the country, there was no pharmacist included in the team. I thought that this team was taken for training. They were taken for training on issues of donning and doping. Doping is how to put on the PPE, and doping is how to remove the PPE when you come out of the unit. And the team was trained on the doping and donning procedures. They were trained on the PPEs that will be used, the medicines that will be used. But then after that, we were not on the team, so we were not trained. But then along the way, when they started realizing our role on that, then they put that on the team, and so we just started our season without people training, and no one even came into do that we are doing very well, but we were able to learn on job, and now we are on speed with the other things. Lastly is the rapidly changing guidelines. As you may realize in my presentation, at first we started, for example, on the treatment. At first we started with chloroquine and hydroxychloroquine for all our conditions. Currently, we don't give any medicine to our compound plants unless they complain of any other infection or comorbidity. But if they don't give them anything. Apart from advising to hydrate as much as they can, and then to also do exercise within their quarantine rules. So how is that a challenge? That means as an logistical person, I had to make sure that we have adequate chloroquine and chloroquine. But I don't know it changes to no chloroquine or hydroxychloroquine. That means I thought that before I'm going to remain there without being used. Yes. I think the resources would be other usable commodities. So that is a bit of a challenge. I like to be changing guidelines. And so we started with just overall. That is the white gowns with the hoods for sharing in the farm plan. But along the way, what else organization came out with another guideline? Those gowns we made for Ebola because you know that it's virus. You can contact it to anywhere as long as you have contact or a confirmed client on your screen. So we started with that, but along the way, what else organization came up with another guidance that we did not need coveralls for instance in rooms of confirmed clients, but rather we needed the surgical gowns, those are the blue ones, and then the N95 and maybe the face shields and the gloves and the gumboots. So what does that mean? Before, I have to make sure that I order for enough stock of coveralls. But then along it changes. That means that coveralls are going to remain there without being used. These are something that have been used for the other useful resources. So those are some of the challenges that we are facing as a team, basically as a pharmaceutical. Yeah. Thank you so much. Allow me in my presentation.
Thank you very much, Dr. Ismail. Thank you so much. So we have a number of questions. I'll start with my own question. So I want to ask you on the mental health challenges you're facing as someone working on the front line. Did you have?
You're not so clear.
I'm asking, did you experience any mental health problems? Like as a person, you know, being on the front line, were you scared of contracting the virus yourself? I mean, how are you dealing with the anxiety or maybe the stress that comes with working 24 hours? How are you dealing with that? Yes.
Hello?
Yes.
Sorry?
I'm asking.
Yes.
How are you dealing with the mental health challenges working on the front line? Were you anxious at some point of contracting the virus? Were you stressed working 24 hours? How are you dealing with that?
Yeah, definitely. Just like any other human being, you when you're faced with a new challenge, you're anxious. You don't know what's going to happen to you, and because we used to see. To watch news and fellow health workers in other developed countries with probably better health systems like Italy and UK and other European countries. Health workers were contracting the virus. And so we're also scared and worried. But then the Ministry of Health came up with they deployed a psychosocial team at the facility. And so on a regular basis, the psychosocial team would meet groups of health workers and try to get their challenges and try to find solutions for them. And of course, they used to, they would give us, doing it, moral boosters, but also, the motivation our leaders used to motivate us, and the World Health Organization team came and reassured the team that in case anyone contracted the virus, they would give compensation. So those words strengthened the team and again strength. But at first there was that anxiety.
All right, thank you. There's an interesting question from someone called Nasi. She's asking, what is the role of pharmacy in pharmacovigilance in COVID? What is the role of pharmacy in pharmacovigilance in COVID-19 management? So have you been doing any pharmacovigilance work, like reporting adverse drug reactions? Have you done any pharmacovigilance work?
Yes. In my presentation, I said that because the main drugs that we're giving from our patients, this goes about this for ISS, that is, I said before, patients who are hypertensive. We have patients who are hepatitis B and the confirmed plan. Apart from those patients with comorbidities, yes, patients who didn't have any comorbidities, the main drugs that we're giving to them were chloroquine, depending on availability, mainly availability. In case availability wasn't an issue, the first choice was hydroxychloroquine, and then tomycin and paracetamol, because almost all our patients had high fevers. So the main pharmacovigilance measure that we're doing is the measuring the measurement of the performance of the heart. And so we'll enter in with a cardiologist on a regular basis. I'm forgetting his name, but he's a cardiologist from Monaco. On a regular basis, we go with our radiology, with our radiographer. We go in and then perform ECG on these patients. So I think as far as pharmacovigilance is concerned, that is basically what we're doing.
Thank you. There's a question here. How do you deal with the challenge of lack of recognition? How are you dealing with it as a pharmacist? Of lack of recognition, how are you dealing with it, or how did you deal with it?
Yeah, I know. I think now this is one of the few platforms that we're trying to use to make sure that yes, there are these health workers that are doing the management, but there are also others that are part and making sure that the team fulfills well and achieves that. So I think it's mainly those such webinars, but also we are, as a team, we are trying to write articles, come up with articles basically about our observations as being part of that team. For example, there's an article that I'm going to share with one of the senior pharmacists. As a team, something we observed because one of our confirmed clients was a female from Rwanda. She traveled from Rwanda. She came in the country, and then she stayed with her husband for 1 week. So when she was tested, she tested positive. When they tested the husband also tested positive. They had 4 kids, and so they were staying with their kids. When they were admitted, the kids were also swabbed and tested. The kids tested negative. But then these kids were staying with the mom and the dad. And so when we tried to find out where the kids would stay, one of them was I think 7 years, the other one was 5, the other one was 3, and one was 2. So they were very young kids. So when we brainstormed on where they would stay, the adults, that is the mom and dad, said no, we want to be quarantined with our children. We have nowhere to leave our children. So the hospital was in the Hema, and so that decision was okay, fine, let's just stay with their parents. And actually, a confirmed woman and with her husband stayed with their kids, and they stayed in hospital for 3 weeks. So on that sense, because we usually take off follow-up samples on day 10, day 14, and then depending on the results, that the patient is discharged or they continue remaining in quarantine till they turn negative. So when these patients were swabbed on day, remember they were staying in the same room with their children, so that when they were swabbed on day 10, they still turned positive. They were still positive. But at the same time, also the kids were swabbed. They also came back and the kids were still negative. The adults were positive, the kids were still negative. Then they were swabbed on day 16. On day 16, when they swabbed the parents, the adults were still positive. The kids, the 4 kids, all of them, they were still negative. And until when the adults turned negative, or I think it was around day 21, and then they will discharge. And the kids still on discharge, they will still shocked and they will still happy. So that is very confusing because like the virus is spreading through because when someone speaks or sneezes or talks, we think they push out some droplets of the virus, and when someone inhales or touches, they touch their mouth, nose, or eyes to contact. So there's no way these kids wouldn't have touched something that touched one of their eyes, mouth, and nose. So we're asking, why is it that these kids never contact the virus? It's just an observation. No one has an explanation for it, but we are planning to write about this and very many other observations. So we think by doing that, maybe the team will be being recognized. Thank you.
Thank you. Just a few more questions. Some of the questions actually you answered them in your presentation. There's a question from Daniel. What is the percentage of asymptomatic patients? Yes, Ismail. What is the percentage of asymptomatic patients in Uganda, and what is the most common symptom in Ugandan COVID-19 patients?
The most common symptom is fever. However, it's fever. That is temperatures.
Okay.
However, most of our clients that we are receiving at the facility are asymptomatic. Most of our patients are symptomatic. I may not have the percentages on fingertips about the national statistics, but at the facility, that is the case at the Untitled Hospital, most of our cases, most of them, they are symptomatic.
Oh, okay. Thank you. I don't know if you have made observation. There's a question from Ray. What are the effects of COVID-19 on the red blood cells and the CBC? Have you made any observations how the CBC of these patients were affected?
There are no any peculiar observations on that.
Okay. Thank you.
However, for each and every patient, one of the routine tests that are done on them is of course the CBC. We do the renal functional test and then liver functional test. And then the other part, that is the temperature, the BP, the pulse rate. So the analysis of the results cannot get been done. So I cannot have this on any of that.
Okay, thank you. There's a question from David. So what strategies can be used to optimize the use of PPE, especially masks, in private hospitals, given their scarcity and high costs? So what strategy would you give to someone working in a private hospital on how to optimize the use of PPEs?
The use of PPEs because in private, because just like I said, it depends on where you are. Because the treatment zones are divided in two levels. There is level 1, which is the cottage, where there is possible contact, and then level 3, where there is contact, and then level 4, where there is contact, and then the patient is producing aerosols, or you're performing procedures on the patient, and then those procedures are likely to produce aerosols, such as a CPR, or maybe you're doing a bronchoscopy, things like that. So in private hospitals, it would depend on basically what you're doing and probably where you are. For example, if you're handling a suspected client of COVID-19 and these are clients are performing procedures onto them that are able to produce aerosols, so these patients are very symptomatic, are coughing, what. Yeah, it is not. It is inevitable not to use. You have to use the energy, even after using it, you have to dispose it off. But on the question of maximizing the state of our facility, at the start, we had a very big challenge of N95s. They were really very scarce. And remember, this is our main tool as health workers as far as our protection is concerned. So we really had a scarcity of this, and that is what we would do. Of course, we didn't have very many ideas, so we're just proposing on how to maximize, make sure we were not infected, but also the patient and giving services. So this was to do. After entering the, at first, of course, we would first put on the surgical mask, and then after putting the, then on top, we'll put on the N95. Then when we came out of the corner treatment units, that is the unit with patients, to disinfect the N95 and then leave it in a room with aeration for about 7 hours, and then we'll use it again. But then later, as we kept on discussing as a team, we realized that that was something wrong, very dangerous that we're doing, because I remember that the N95 has layers like filters. So whoever would, so if spreading them with the alcohol, the disinfectant, there was a possibility of loosening the filters. And so the other idea that we came up with is the usage of the infrared lights, because remember also the infrared is able to cause disinfection. So probably that's also that can be an idea in facilities with SPPEs. To try to use the infrared to cause disinfection of the coronavirus, and then we use the mask after that.
Okay, thank you. A question from Claire. She's asking, are you seeing any hospital transmission? She's saying majority of the cases at her hospital in the UK are through hospital transmission. So at Entebbe Regional Referral, are you seeing hospital transmission?
No, I can't hear you.
Okay, the question is, are you seeing any hospital transmission at Entebbe Regional Referral Hospital, like transmissions happening within the hospital? Are you seeing any such cases?
My observation as one of the health workers on top line, as one of the health workers on Frontline, my observation is actually coronavirus is I think even its transmission is not fixed. Because let me just give an example. At the facility, sometimes you would get actually we're still getting it, because just like I said, currently we have 111 confirmed clients in the hospital. So sometimes we are challenged with space, inadequate space, and so patients end up being in the same room, like a room. It could end up housing 4 patients, 4 or 5 patients, depending on the size, and then also considering the 1 meter distance. But of course, these are adults. You cannot keep them on the bed all the time, so they keep on eating, sharing, and then also they use the lavatories. But then when we do the follow-up samples, for example, there was a room that had 4 confirmed clients, but then when we did their follow-up samples, the 3 are turned negative, but then the 1 was still positive. But then these are patients that were in the same room, were always conversing together, they were always playing games together, they were always sharing the lavatories together. So it was a little confusing. Why? Because they have a very high possibility of cross-contamination and maybe cross-infection. But why did this one stand negative and then this one this one still remains positive. So I don't know, but maybe there's no cross-infection. Maybe it's really complex.
Okay, thank you. Just, I think 2 more questions, then we'll close it. A question from Godwin. How do you respond to someone who comes to the pharmacy to get flu drugs but has COVID-like symptoms? You got the question?
Yeah, I got the question.
Okay.
Because even at the facility, we don't offer other services. We are now basically offering COVID-19 management services. So if someone comes and then we need to take a test because you know the COVID-19 is very expensive, very, very expensive. So you don't do it on anyone. So I think that the strategy here is very high index of suspicion. But I think we're all supposed to have a very high index of suspicion, and maybe the basic knowledge of COVID-19. For example, someone is coming from deep the village, and they've not had any contact, any history of travel. They've not had any history of contact to a confirmed parent, and they are not coming from a region that is highly suspicious, and then they are presenting with COVID-19, which we all know very well, that also the other infections, specifically like flu, can present with the same signs. So if there is no high index of suspicion, unless otherwise, why would you take the patient to take a test for COVID-19? So it's basically having a high index of suspicion.
Thank you. I think just to add on that, like if you, for example, work in a community pharmacy, I think having some of the basic safety precautions in your pharmacy helps. For example, social distancing of the clients who are coming to access your services, doing continuous disinfection of the surfaces, wearing masks when you're serving your patients. All those measures, I think, can help mitigate the risk of, let's say, someone, a COVID-19 patient spreading the virus in a community pharmacy. So one last question. This is just your general observation. There's a question here. Do we really need to be strict in our lockdown measures as compared to more affected countries, as these measures also kill people?
Are we supposed to be strict on?
Do we really need to be too strict in our lockdown measures? Because this person is saying the lockdown can also affect other people. People die of hunger, lack of money to buy medication. So the question is the strict lockdown measure, I think that we had for the last 3 months until I think 2 weeks ago, is the strict lockdown measure really necessary? That's the question.
Yes, Kenneth, thank you so much for that question. It's really very hard one to answer. I wish I was a policy maker. I wish I was part of the team that makes policies for the country. But just to give an example, an experience. I have a friend who is a pharmacist. He's working in the UK. So as part of the health worker who is on the front line, I was tempted to ask them how they manage the virus in their country, that is UK. And specifically the question was, how do you manage COVID-19 patients who are asymptomatic without any other comorbidities? And she told me what they do in the UK is if someone is asymptomatic, they don't have any symptoms, that is symptoms like deep in-breathing, symptoms like respiratory distress, respiratory distress, symptoms like hypothermia, they are not coughing. So what they do to them is they advise them to stay home, quarantining. They give them numbers. This is what she told me. They give them numbers to call on in case things change. And then they advise them to rehydrate. That's what she told me. And that's what they do outside. Why did I say that? Most of the patients that we receive at our facility, now this is just an observation. Almost all the patients that we receive at our facility are asymptomatic patients. And probably that's why they were looking at video circulating on social media in one of the facilities. But that wasn't intended for some other facilities where patients were dancing, they were taking videos. Although it was true, but then most of our patients are very asymptomatic and they look normal and they look very stable. So answering the question, do we really have to be very strict on the lockdown? I don't know. It depends on what our objective is. If the objective is preventing the spread of the violence into the community, then maybe yes, we need to be very strict on the lockdown and the other preventive measures such as hand washing, putting on a mask, and social distancing. But then what about if we think about another objective of strengthening the health system? Because stopping the spread of the violence in the community is really very hard, and I think our health system is really going to be a very hard nut for us to crack, stopping the violence from spreading to the community. It's going to really be very, 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 very hard. So for me, if I was to make a decision, what that I would go with is maybe to make sure that we strengthen the health system and not be very strict on the lockdown, because people are going to, according to what we've seen and what we've observed, people are being quarantined, and then after some time they turn negative. So what about if we strengthen the health system and then we start being prepared to look out for those severe cases and then maybe quarantine those ones? I don't know. That's what I think as an individual. But probably the government thinks otherwise. So we have to be strict on the lockdown. I don't know. But in other countries, asymptomatic patients are not taken to hospital, but they are quarantined from their homes. And for us here, we are actually at our facility, we have not gotten any asymptomatic patient. That is a patient who needs ICU services. Despite the fact that we have so far admitted 166 patients.
Thank you very much, Ismail. I think that is the last. So, I mean, just give us your closing remarks and then we close. Your closing remarks.
Yes, Kenneth. People outside. Am I clear and audible, Kenneth?
Yes, you're clear and audible.
Yes. There are so many rumors outside. People saying that probably coronavirus is not in the country. Maybe just a money-making project or something like that. I would like to assure all the attendants on this webinar that yes, coronavirus is there in the country. People are testing positive, so the virus is actually there in the country. However, most of the patients are still asymptomatic. Now, probably that is something that as pharmacists we probably could go in and find out why. Most of our patients are asymptomatic. They don't have those serious symptoms. I don't know why. Currently, at the facility we have 111 confirmed clients. That is according to results from the national laboratory, from the national testing hub. That is PPHL. So my advice would be yes, as pharmacists or any other health workers or any other individual that are attending the webinar, we really need to take into caution the preventive measures, that is putting on of the mask, doing the social distancing, the hand washing, because the virus is there and it is real. Thank you, Kenneth.
Thank you so much, Ismail, and we are glad we're able to hear from you, and I think so many people are eager to listen from you, to share your experience on the front line. So thank you so much. And thank you so much to our attendees for bearing with us even during some of the technical challenges. So thank you so much for keeping. So as you leave the webinar, please fill the feedback form. We are going to share this presentation with you, and also and the slides and also the recording. We'll email it to you tomorrow. So thank you very much, and stay safe. Thank you.
Thank you so much, Kennedy. It's really very much for that.
Thank you.